Thank you for the opportunity to present our work. This paper looks at a survey of current VTE chemical prophylaxis in UK hip and knee surgeons in relation to the publication of the recent NICE guidance, and these are our disclosures. So debate continues about which VTE prophylaxis to use in arthroplasty patients, and in 2018, NICE published their updated guidance on this. For TKR, surgeons can choose between a DOAC, low molecular weight heparin, or aspirin alone. And for hip replacement, the only caveat when using aspirin is that you need to use 10 days of preceding low molecular weight heparin. NICE also made some research recommendations, which include the role of aspirin monotherapy, and also the duration of prophylaxis after hip replacement. But little is known about the current UK practice for VTE prophylaxis after hip replacement and knee replacement, and the appetite of surgeons for future research. So our study aims were to assess current practice of VTE chemical prophylaxis for hip and knee surgeons to see if these practices changed since the NICE publication in 2018, and also to determine the equipoise of surgeons for future research in this area. So we undertook a survey of 306 surgeons at 187 units spread across the UK through two sources. The first was through the British Hip Society members through an online survey, and we asked specifically about hip and knee replacement practice here, and also the regional trainee-led networks and research collaboratives were involved in this survey. Questions which we asked about VTE chemical prophylaxis included the drug, dose and duration in a typical low-risk patient having hip or knee replacement, both before and after the NICE 2018 guidance was issued, as well as surgeon equipoise for future RCTs. We then examined the trends that we saw, and in total we had 258 unique THR surgeons and 253 unique TKR surgeons. So for the primary hip replacements, first of all, post-2018 NICE guidance, 34% were using low molecular weight heparin alone as VTE prophylaxis, 33% were using aspirin, most commonly preceded by low molecular weight heparin, and 31% were using DOACs. 34% of our hip replacement surgeons changed practice since 2018 NICE guidance were issued. The main change was an increased use of low molecular weight heparin followed by aspirin, which changed from 25% pre-2018 to 73% post-2018. And there was also more compliance with the NICE guidance post-2018 from 86% to 93%. For knee replacement, 42% of surgeons were using aspirin, usually as monotherapy, 31% were using low molecular weight heparin, and 27% were using DOACs. 41% of knee surgeons changed their practice since 2018 NICE guidance was issued, and the main increase here was in the use of aspirin monotherapy, which substantially increased from 18% to 84%. And again, there was more NICE compliance post-2018 with almost 100% compliance now with NICE guidance. In terms of surgeon equipoise for future research, 48% of surgeons surveyed would participate in a two-arm trial comparing aspirin with a DOAC alone in hip or knee replacement patients. This increased slightly to 51% if a third arm was added to the trial, which was low molecular weight heparin. And then when we asked about standard versus extended prophylaxis of one single drug in hip replacement, the answers were dependent on which drug was being used. So 80% of surgeons would participate if the drug being used was low molecular weight heparin, but this dropped to 43% if it was dabigatran. So current UK practice for VTE prophylaxis is varied. For hip replacement, the three main regimens are split equally between surgeons, but for knee replacement, aspirin monotherapy seems to be preferred now. Since the NICE guidance was published in 2018, over a third of surgeons have changed their practice, and overall there is improved compliance with the latest NICE guidance. The major shift is in the increased use of aspirin, and this is supported by the literature with our recent meta-analysis shown here, where we also found aspirin as effective prophylaxis for VTE prophylaxis in arthroplasty. And in terms of future research, the surgeon equipoise depends on the clinical question, and the best equipoise we found was for a trial comparing standard versus extended low molecular weight heparin in primary THR patients. Thank you for your time. I'd just like to acknowledge the British Hip Society Research and Executive Committees for allowing us to circulate the survey to members, and also the regional training networks and collaboratives, as well as my co-authors who are listed here. Thank you.